Okay, this is the last lecture in our immunology series, and this one's going to be really quick. There's not a lot that you there's not a lot you need to know for chapter 39. So I'm going to point out the stuff that I want you to know. So chapter 39 is talking about the rheumatological disorders. When you hear the word rheumatology, rheumatological disorders, that's basically talking about the autoimmune disorder. So, you know, in this series we've been talking about immunity. In a rheumatological disorder, that is an immunity that is not associated with an external antigen. It is an autoimmune disorder, which means that parts of the body are being identified as the foreign object. And so the problem is all that same stuff that occurs in the immunological response, the initiation of the T cells, the B cells, the inflammation, all of that will occur, but there's not there's not an external pathogen or a virus or a cancer. The body is identifying parts of itself as foreign and attacking it. And it's difficult to treat. There's not a cure for most of these. There's just treatment, and the treatment can be difficult. So I'm just going to go over the ones that I want you to know in this series. So these are the ones that are most common. You're most likely to see these in your practices. The first is arthritis, and I want to point out, I don't think that your book does a good job at all talking about the difference between rheumatology or rheumatological arthritis, RA, and osteoarthritis. They've lumped both of those things into the same chapter, but I don't agree. I do not think that osteoarthritis should be in the rheumatology section, because osteoarthritis is the arthritis that most people say they've got arthritis. If that's osteoarthritis, that's just a destruction of the joint, typically by overuse, exercising, things like that. It's not a rheumatology thing. It's not the body is fighting against its own joints. It's the joints have been overused. It can occur in younger people, but typically it occurs in people that have overused their joints, or and you see a lot more often in the elderly. That's not a rheumatological disease. So I don't know why it's in the rheumatology chapter. I don't even want you to read it. I don't want you to look at it. We're going to talk about osteoarthritis when we talk about orthopedic things. Then we'll talk about it then. So just gloss over that when you're reading through it. I do want you to focus on rheumatoid arthritis. Rheumatoid arthritis is much different than osteoarthritis. Rheumatoid arthritis affects all the joints. Unlike osteoarthritis, it just pretty much affects the joints that have been, like if you're a football player, your knees and your hips are going to be hurting. If you're a tennis player, you're gonna, your elbows might be hurting, things like that. Rheumatoid arthritis is systemic because all of the joints the body is identifying as foreign, and so they will start attacking. So the joints get very red, they're swollen, they're very stiff. They're real stiff in the morning. They get a little bit better with movement. They can be red, swollen, painful. They can start causing joint distortion, like you see here. See how the joints are actually starting to distort? In osteoarthritis, that doesn't occur. You can get some enlargement, but you don't start getting some distortion like you do in rheumatoid arthritis. So we want you to focus just on rheumatoid arthritis. And that's probably the most common of the rheumatological diseases. The next one that you've probably heard about is lupus. Systemic lupus erythemus, SLE is what it's called. Lupus is an autoimmune disorder that affects the connective tissues. This one probably has the potential to be the most deadly. People can live with it for a long time. Lupus has quite a bit of variant. In most of your rheumatological disorders, there's pain involved, because there's three components with any of the rheumatological diseases. And those three things involve inflammation. There's an autoimmune component, meaning the body's identifying itself as the foreign agent, and it's degenerative, meaning that it will start to destruct something or break something down. Lupus has this classic butterfly rash to it. It highly affects the skin, so your lupus patients should not be out in the sun. I think I mentioned this in a previous lecture. But it also affects the internal organs. It can lead to cardiac problems. It can enlarge the heart. It can lead to pericarditis. You might hear that friction rub. It can lead to kidney problems. Artery problems can lead to arteritis, where the arteries get really hard. So people can die from lupus. Most of them don't, but it can be just mild symptoms all the way up to death. Lupus is way more common in women than men. They're not sure why people get lupus. There's currently no cure for it. They believe that there's like a genetic component plus an environmental component, maybe sex-linked chromosome, because it's got such a high likelihood to occur in women. So that's lupus. So rheumatoid arthritis and lupus are two of the most common of the rheumatological disorders. The other one that's less common, but it's fairly debilitating, is ankylosing spondylitis. Ankylosing spondylitis, it starts occurring earliest in the lower spine, and it starts kind of fusing that spine together. And somebody who's had ankylosing spondylitis for a long time will end up starting to slump over like this, and that lower spine right here kind of starts fusing together, and then the patient starts doing this. You can see this x-ray here, see how that spine is starting to curve up like that. That's ankylosing spondylitis. That's another rheumatological disorder. Sjogren's syndrome is one, it's not as common as the other two that I mentioned, but you might see this. Sjogren's syndrome affects the moisture producing glands. So people that have this disorder, their eyes are very dry, their mouth is very dry, they can have vaginal dryness, their teeth, they start having teeth deterioration because their mouth doesn't stay moist. They have really cracky skin because their skin, they have no moisture in their skin, so it's just a very dry disease because the body is attacking the moisture producing glands. And then the last thing that you'll probably hear about or see in your nursing career is scleroderma. Scleroderma is a rheumatological disorder that affects the skin and the internal tissues, and it causes them to be hard. So you'll see this person's hands here, see how the joints, like the skin folds and stuff, are gone, and the joints, it looks like a burn patient basically, because the skin is becoming very hard. So that's known as scleroderma. So those are the ones that I want you to focus on when you're studying this chapter. There are your book will talk about the extra-articular, meaning outside the joints. This word here, articular, means joints. So beyond the joints, there's a lot of problems with the rheumatological disorders. The number one being pain. This is very painful. All of those diseases that I just described are painful because there's an inflammatory response, and inflammation typically leads to discomfort. Patients can have fever. Oftentimes they will have fatigue, so it's really important as a nurse to allow for periods of rest. You would teach your patient that has RA or lupus or something like that to get up in the morning, make coffee, maybe make breakfast, and then go sit down, read the paper. Then get back up and go take your shower, and then sit down and rest, because you want to allow for periods of rest because you don't want the patient to fatigue. These patients that have these diseases are likely to be anemic, so nutrition and protein and things that are going to help increase a patient's hemoglobin and hematocrit are significant. They can develop lymph node enlargement, so when you're doing an assessment, they may have enlarged lymph nodes. Like, remember, I can't remember what lecture it was where I showed you where all the lymph nodes are. You've got them in your neck, in your axle, in your groin, some in your gut. Those can start enlarging. Raynaud's syndrome and Sjogren's syndrome, they can, like Sjogren's disease can be a standalone disease, or it can, patients who have lupus or RA can also start developing some of the drying effects like patients that have Sjogren's do. Raynaud's, because of the impact on the arteries, and that sometimes the arteries can start hardening, the patients can get Raynaud's syndrome. which is a disorder where the nerves going up into the hand, because this band right here gets swollen, so the arteries and nerves going up into the hand get compressed, so the fingers get very cold, especially in cold weather, and that's very painful. It's kind of like getting frostbite. And any organ system can be involved. So this is why when you're doing an assessment on a patient who has a rheumatological disorder, you really need to make sure that you are assessing all the organs, because any of them can get affected. So you're going to want to get, like the renal labs, the BUN and creatinine. You want to check the hemoglobin and hematocrit. You want to listen to the heart, see if there's a friction rub. The friction rub is real common. Like, remember when we talked about the inflammatory diseases of the heart, and the pericarditis can lead to that friction rub when you're auscultating the heart, so you want to listen for that. And a ton of skin and mucosal problems can occur. And what happens, because there's a skin involvement and the arteries can get involved, the lack of oxygen to the tissues will start occurring, so the patients can get lesions and skin deterioration because of inadequate amounts of oxygen to the tissues and the organs. So these are the things I want you to know for this chapter. I want you to know how to assess a patient that has rheumatological disorders, and the chart on 39.1 I think is a good chart for that. I think you should spend some time with that. The labs are also important, and the labs can be found on table 39.1. Now, the labs that I really want you to focus on are, one is called CRP, your C-reactive protein. The other one is your ESR, your erythrocyte sedimentation rate. Both of those, your CPR and your ESR, are classic labs that identify inflammation. And in your patients that have rheumatoid disorders, because they have an inflammatory component to them, their ESR and their CPRs, or CRPs, sorry, their CRPs will be elevated, and that's one of the manifestations that would lead a person to make these diagnoses. In most of these diseases that I just mentioned, there's not like a standard marker. There's not like a test that you can run and say, oh yeah, this person has lupus, or oh yeah, this person has RA. You start putting all the pieces together. Like the patient who has lupus might come in and they're having skin lesions, skin rashes, fatigue, pain, and then you can start getting some of these labs. They may have an elevated creatinine because it's starting to affect their kidneys. They might have elevated C-reactive protein and elevated SED rates, ESRs. And so you kind of put all those together, and then you make the diagnosis that the patient has lupus or RA or something like that. So kind of know some of the labs, but really you don't need to know the specific numbers. I just want you to know which ones, and really just focus on those two that I just kind of mentioned. And then the medications. The other problem with your patients who have rheumatological disorders is there's no cure. So patients are on a lot of medications in order to control all of the symptoms of this. So oftentimes they are on pain medications to control the excruciating pain that they're in a lot. And so they could, usually something like an aspirin helps with that. But then of course your aspirin, you can get toxicity, it can cause the blood to thin. Too much aspirin can cause ringing in the ears, so there's some complications with aspirin. They're usually on some of the NSAIDs, and by the NSAIDs I mean the non-steroidal anti-inflammatories. Motrin, Advil, naproxen, you can get them over the counter, and they're great for an anti-inflammatory. The problem is with extended use and high uses, they can also lead to stomach ulcers, so you have to kind of watch out for that. Patients who are getting high amounts of Tylenol, and Tylenol is great for pain, but again, the Tylenol gets metabolized through the liver, and so the patient can start having liver problems. You need to follow their liver enzymes and make sure that the Tylenol is not also contributing to liver degeneration, because the connective tissues or the rheumatology disorders can also affect the liver.